and Response Unit at the Ministry of Health. They'll be talking to us today about the current testing, the sequencing, what variants we may have, and what our local data shows. Then we also have with us Dr. Frederick Wangai, who is from the University of Nairobi, and will just be giving us some updates on management of COVID-19. And then we have Dr. Phoebe Juma from the Kenyatta National Hospital, who will be talking about long COVID, and then we'll be able to answer any questions you may have. So feel free to put your questions in the Q&A, and we'll get to them at the end of the session. So just to start us off, allow me to, may I kindly request the host to stop sharing so that you can allow us to share. Oh, thank you. So to start us off, we'll just look at what's happening in the world of COVID-19. And to close something. Okay, so globally, where are people? And what I did was looked at some of the data summaries, one from our World in Data, which is free and an open source that has very good visualization of data, and also from the WHO dashboard. So from our World in the Data, looking at sort of them weekly confirmed, so these are cumulative cases over the last week or so. And you can see that as of June the 20th, so just about 10 days ago, there were very few cases. Most countries reported 0 cases. Africa, there's maybe just a few countries reporting very few cases. There are a few cases in Brazil and the UK. Over the last few months, we've noted Japan has had quite a number of cases, but this seemed to have come down significantly. And many of the countries are now reporting very few cases. So this always, again, reporting is based on how much testing is being done and how well countries report. But at this point, you're not seeing a major signal of COVID-19 from most of the countries that report. If we look at the WHO dashboard, same thing. Over the last few months, there have been very, very few cases globally. And if we look at deaths, as of June 26th, about 218 deaths reported, and that's global deaths reported. Many of these may be associated with, but only a few are actually attributable to COVID-19. Again, from our World in Data, if we're looking at the weekly confirmed deaths, we have very few deaths in, again, most of the countries. Africa here was bunched to one country just because there have been very few cases over the last several months. But as you can see, no major signal from any of the other areas. The last situation report that I saw from the Ministry of Health was, I think, released on the 26th of June, so about 4 days ago. At that time, there were 0 confirmed cases and 0 deaths. And as many of you may note, and in the hospitals in which you work, you can put in the chat and let us know what you're seeing in your hospitals. We've been seeing very few cases. About 2 or 3 weeks ago, there was maybe 1 or 2 more cases than had been seen in the preceding weeks. But at the moment, again, we're not seeing a major issue. There were a lot of questions, I think, last week or the week before, when there was an alarming article in the paper that suggested that hospitals had run out of oxygen because of a lot of COVID. But again, checking in with a number of facilities around the country, they were not in any way overwhelmed. Majority of the facilities did not have any cases. And those that had cases, many were mild or were coincidental diagnosis in patients who had presented to the hospital with issues other than COVID. So again, even in the country, and we'll hear more about what our local data is telling us from Dr. Okunga, but no major signal at this point. So as I just said, few isolated cases over the last few weeks, very minimal with critical illnesses, but we've had a lot of URTIs. Over the last several weeks, there have been a lot of patients presenting with features of upper respiratory tract infections. And where there was testing for specific organism, there's been a bit of influenza, respiratory syncytial virus. And just a reminder that majority of upper respiratory tract infections are self-limiting, and there's no need for antibiotics. I say this with passion, just because we like to do antimicrobial stewardship. So I will stop at that point. Thank you very much. And I will now invite Dr. Okunga to make his presentation. Dr. Okunga, karibu.
Thank you, Dr. Mbajo. Thank you, all colleagues. So let me attempt to share my slides. My slides visible?
Yes, we can see them. And I realized I didn't put mine on slideshow. So if you can, please put yours on slideshow. Thank you.
I'll attempt to, so, okay. Sometimes placing them on slideshow disappears. Is that visible?
Yes, very good. Thanks.
Okay, so thank you again, Dr. Mbajo. I'm Dr. Kunga Emmanuel from the Ministry of Health, from the Division of Disease Surveillance and Response, where I had the Integrated Disease Surveillance and Response Unit. So today I'll be presenting to you on something on the COVID-19 testing scenario in the country, circulating variants of concern. I'm not a lab expert, so I'll be presenting from the surveillance perspective, the epidemiological perspective. So currently we monitor the COVID situation through a variety of surveillance systems. We have the routine surveillance within the health facilities where we collect indicator-based surveillance as patients are treated. Then we also have an influenza sentinel surveillance system in the country, through which we also testing for COVID. And we also we've initiated COVID mortality surveillance in the past 2 months or so, where we are able to pick up missed COVID plausible cases from postmortem samples. So in terms of testing, so far since the beginning of the pandemic, we've tested more than close to 4 million people, or we've conducted close to 4 million tests. These include both PCR and the rapid diagnostic kits, and our cumulative number of positive cases has been 343,786. Cumulatively, our recoveries have been that, which represents about 98.3% recovery rate. Cumulative reported deaths are 5,689, with a case fatality rate of 1.7%. So I know when we look at death, there are a number of community deaths that could have been missed. So that's another discussion. So when we look at the current testing and positivity rates, first we must highlight that the number of tests conducted has fallen very significantly. And therefore, for us to track the situation in the country, one of the key indicators we are looking at is more of the positivity rate. But even as we look at positivity rate, the minimum number of tests required as per WHO guidelines is also important to consider. So lately in around week 22 and then 24, 25, you can see we've had a bit of an increase in positivity rate approaching 10%. Although the number of tests conducted has been largely low, less than 1,000 per week in most of the weeks. So in terms of the variants of concern circulating, and this week, as I'd indicated, we pick from sentinel sites. From what we've seen between April and June 2023, the predominant circulating variant is Omicron XBB. And the main, if maybe I could talk about where we've collected these samples. We've collected the samples we use for sequencing from Makueni, Kisumu, Nakuru, Nyandarua, Busia, Nairobi. And the age range for the samples, as you can see, is quite wide. And most of all the cases were Kenyan residents. So the results are largely that. As you can see, the main variant that's circulating is FY.4 and GE1. GE1 is basically XBB 2.3.10.1 and FY.4 is an XBB 1.221.1.4. So when we look at the trends of those variants, then you can see that there's been a slight predominance. This is not a very representative sample, but as you can see towards the tail end of May and early June, we've isolated more GE.1 and a bit of the XBB 1.22.1. Now, through the COVID mortality surveillance, because we need to triangulate a number of surveillance systems to be able to really understand the situation in the context of low testing. So from the COVID mortality surveillance from May to June, we've enrolled 94 patients who ended up dying as a result of respiratory illnesses. And out of these 94 that we enrolled, of course, they came from Busia, Nakuru, Kapenguria, Loitoktok, Makueni, as you can see there. The overall positivity for COVID was 12%. And when we look at the detection rates, you can see towards June, we are having about an increase of positivity rate to about 21%. And we look at the age distribution of these patients, the majority above 65. So what are the implications of those findings? For us, I think we are saying that it is true that the absolute cases may not be very high, but this is influenced by the testing rates. So we need to increase testing, particularly for all persons presenting with respiratory illness, whether it's flu-like in the OPD or severe acute respiratory illness in our wards. Look, because of the age distribution of these deaths, we're also saying we may need to protect our older persons a little more. So we are enhancing our sentinel surveillance also. We currently have 8 sites, but we want to make it more geographically representative for the country. Then because of these undetected cases in hospitals, we need to protect our healthcare workers and other patients, and probably we should now be recommending more respiratory precautions as we go ahead. So thank you very much, Dr. Mbajo and colleagues. think that is the end of my presentation.
Thank you very much, Dr. Okunga. I think that's really excellent work. Doing the community surveillance is really useful for knowing where we are at and even for identifying some of these deaths. So thank you very much. I think I will now invite Dr. Wangai. Please go ahead with your presentation. Dr. Wangai, I don't know if you're able to hear me. Okay, all right.
Can you hear me now?
You sound really far from the microphone.
Oh, okay.
Now we can hear you.
All right. Thank you very much for inviting me to give this talk. Let me put on my slide. All right. Are my slides visible?
Yes, I think this is, yes, it starts with the poster.
Yes, yes, it does.
Okay, yes, then it's visible.
Okay. Okay, thank you very much. Yes, now we will shift gears a little bit and go to updates on management of COVID-19. What are the latest management of a patient with COVID-19? Do we have any new research that has come out or anything, any new kid on the block for us today? Something that I always like asking my colleagues, and it's just like getting the feel of this. A treatment of a COVID-19 patient, does it include, now I'd like all of us to actually answer this question in our hearts, and also maybe you can type on the chat. Does it include any of the following: ivermectin, vitamin C, vitamin D, and zinc? True or false? Treatment of a COVID-19 patient includes any one or more of the following: true or false? And the reason why I ask again, I see typical prescriptions for COVID-19 where, a doctor has written 1, 2, 3, 4, 5, 6, 7, even 8 different drugs, hydroxychloroquine, vitamin C, zinc, antihistamines. I've seen, azithromycin as well, doxycycline, of course, our favorite ivermectin, again and again and again. What do we know about treatment and management of COVID-19? What works? What does not work? What we know now, lots and lots of data has come out to support that there's actually no role for hydroxychloroquine, no role for azithromycin, no role for lopinavir, ritonavir, interferons, and this has been quite across the board. I can show you many, many, many different RCTs and observational studies, and many clinical trials that have shown no role for vitamin D, no role for zinc, no role for vitamin C as well, no evidence to support any improvement in terms of outcomes, in terms of morbidity, in terms of mortality, vitamin D as well, nothing in terms of even length of stay. So a lot of the studies and research we have show that there's insufficient evidence to recommend any of these drugs for the treatment of a patient with COVID-19. However, now that we know what does not work, we should ask ourselves now what indeed works. What do we have evidence for? And I'll just pick up some of the guidelines from the IDSA, CDC, WHO. Again, all of them conclude there's no evidence to support any of those drugs that I've mentioned earlier. However, when we do have a COVID-19 patient, what are some of the things we need to think of? approaching to a management of COVID-19 patient, we need to think about, as we ask our history, again, back to the basics, history and physical exam. Think about the time and the onset of symptoms. Think about the characteristics. Is the patient who is in the elderly age bracket? Is a patient with comorbidities, for example? Is a patient who is pregnant? Because we know many of these factors indeed lead to poorer prognosis and higher risk of progression to severe disease. We need to ask ourselves, what other diseases or what other differential diagnoses may be concurrently present, or even maybe confounding our diagnosis of COVID-19. Just because a patient is suspected to be COVID-19 does not mean that we forget our medical school knowledge, forget what we've learned through our 5-6 years of undergraduate. We still need to employ our clinical acumen. And most importantly, we need to learn how to grade the severity of COVID-19 in our patient. Is a patient who has asymptomatic disease? Is a patient who has mild disease? Is a patient who has moderate or severe or even critical disease? Because whatever severity this patient has will determine how we manage the patient. Just reminding us that we have guidelines on case management of COVID-19 in Kenya. I'll borrow a little bit from that. In terms of updates on management, we know that for a patient who has mild COVID-19, home-based care is what is recommended. Same as those who have moderate COVID-19. Now, when the patient now is classified as having severe COVID-19, we'd want to have them in hospital, as well as those who are critical. So either in the ward, but now when they now progress to critical, we want them to be managed in the ICU. What does mild, moderate, severe, critical COVID-19 look like? The cutoff is oxygen saturations on room air. Anyone who has less than 94%, that's what we use as our cutoff, in terms of oxygen saturation in room air, is classified as a patient with severe COVID-19. And if they have any other complications, such as respiratory failure, septic shock, or multiple organ dysfunction, that patient will now be critical. These are patients who need to be managed in hospital, and we do know we have certain things to consider when we're thinking about management of these patients. So the first step is knowing how to grade the severity of COVID-19. Secondly, I like using this graph because it really shows us the different things we need to think about when nursing or treating a patient with COVID-19. We know that a lot of the damage to the different organ systems happens in the inflammatory phase and not in the early viral phase. So anything between -2 days before the symptom onset to about 5-6 days, that is when we classify this as the viral phase of the viral shedding, where that happens a lot, and that really now stimulates a later inflammatory phase, or what many of us know as a cytokine storm. So the cytokine storm is what really we need to know how to manage while in hospital. And what are some of the things we need to think about? Again, this is just lifted off the COVID-19 guidelines that many of us have access to. As long as we've been able to make sure that we've classified again and graded the patient severity in terms of moderate or severe, that we must, at that point in time, get some level of chest imaging. Should be a radiograph or even a CT scan of the chest. And if this patient indeed has a high probability of COVID-19 backed by your SARS-CoV-2 PCR results, at that point in time, we'd want to manage them as a COVID-19 severe case. Just reminding us, mild and moderate COVID-19 can be managed at home symptomatically, whereas severe and critical illness, because of the inflammation that we need to now tackle, a lot of data has come out to support the use of steroids, and most importantly, dexamethasone for these patients. Again, as long as they're desaturating less than 94% of oxygen saturation on room air, they classify as a patient who needs oxygen supplementation and steroids as well. A lot of data has also come up to show that these patients would benefit again from prophylactic use of enoxaparin or of any other anticoagulant that is available, for example, heparin, on these patients who have severe and critical illness. So main important, the backbone of therapy, again, is oxygen for these patients and steroids. A lot of data has come out, most importantly in the recovery trial, that showed us that there was a lot of benefit for these patients who were on dexamethasone. If we don't have dexamethasone, we can use other steroid equivalents such as methylprednisone at a dose of 32 milligrams per day, or even prednisone at a dose of 40 milligrams per day. Immunomodulators as well have a role in severe and critical COVID-19. So we know that tocilizumab, again, is one of the immunomodulators which has shown benefit in these patients. However, for those who are on tocilizumab, we need the data that we have supported patients who had a CRP, C-reactive protein level more than 75. So that is what really showed benefit in these patients. A lot of benefit was also was found in Janus kinase inhibitors such as baricitinib, a drug really used very well in rheumatoid arthritis and in many of the connective tissue diseases, but was shown to have benefit in terms of reducing morbidity, especially in the severe and critical patients, baricitinib. And this baricitinib was actually studied initially in combination with remdesivir. Now, remdesivir, on the other hand, we know it's an antiviral that was used many, many years ago for other RNA viruses, including SARS-CoV as well. And remdesivir, however, on the other hand, a lot of data has also not been very supportive in terms of its benefit for many patients who are later on in the disease. So patients who are intubated, patients who are much, way into the inflammatory phase. Remdesivir has not shown too much benefit. So if a patient is ventilated, please do not think about remdesivir. It did not show much benefit. There's a new kid on the block called Paxlovid, which is actually now this is called a tongue twister, nirmatrelvir, yes, which is in combination, sorry, Dr. Lois.
Sorry.
Oh, nirmatrelvir. Yes. Yes, that actually showed that this is a paper that came out last year in the New England Journal of Medicine. In combination with ritonavir, it showed that actually this combination resulted in risk of progression to hospitalization or death, and which was quite significant at about 90% reduction in risk. However, this drug could only or should only be used in patients who are within the 5 days of onset of symptoms. So if someone has had symptoms for more than 5 days, again, mild and moderate COVID-19, then Paxlovid will not work for patients who have had COVID for longer. So knowing the onset and timing of symptoms is important to know if this drug will actually work. On the other hand, nirmatrelvir as well, patients need to be screened for serious drug-to-drug interactions, because we know that ritonavir interferes with the CYP3A system, 3A4 system, and indeed many drugs as well are at risk of getting a lot of interactions when you use nirmatrelvir or Paxlovid. So we need to take good drug history in these patients as well. Also check for other comorbidities such as HIV, for example. Does this patient have HIV and need to be screened? So there are a lot of considerations that need to be taken before using Paxlovid. And lastly, molnupiravir, which has been really marketed a lot over the last few months to about a year right now, again, was authorized for use for mild to moderate COVID-19. However, when compared to Paxlovid, the data was not very good in terms of reduction of risk. Many papers say probably around 30% reduction of risk compared to Paxlovid, which is about 90% within this cohort. Also, we need to remember a few caveats with molnupiravir, such as one cannot use it when less than 18 years of age because of it may affect bone and cartilage growth, and again, contraindicated in pregnancy. Lastly, prevention is always better than cure, so we cannot overemphasize the importance of washing hands and hygiene and preventive measures. Again, avoiding touching mouth, eyes, avoid men. I like this, avoid men. And instead, we need to follow women, wash our hands, social distances, masking, exercise, and of course, no unnecessary traveling. Thank you very much.
Thank you, Dr. Ngai, for a fantastic presentation. I like the follow women part, and no bias on my part. And maybe tell people about antibiotics.
Yes, yes. Again, another of our pet subjects, antibiotics. Just like azithromycin, no other antibiotics have been indicated and have shown any benefit in terms of use in COVID-19 disease. In fact, we have started talking about, there's a lot of research and actually papers that have come out talking about the pandemic within the pandemic. And now we are seeing a lot of antimicrobial resistance as a new pandemic that has been fueled by COVID and inappropriate antibiotic prescriptions in COVID-19 disease. I remember at the very height of COVID, there was a lot of use of piperacillin, tazobactam. There's a lot of use of meropenem as well. And of course, this drove a lot of antimicrobial resistance, a lot of candida in our setup. And again, no use, no benefit in terms of mortality or even morbidity in a patient with COVID-19. So please let us avoid antibiotics because antibiotics do not work in viral diseases. Thank you.
Thank you very much, Dr. Ngai. Thank you for that presentation. And now we'll move on to the last presentation, which is an important area that a lot of people have been asking questions about, and that is the issue of long COVID. And to just give us some highlights on that is Dr. Phoebe Juma. Karibu, Dr. Phoebe.
Thank you. Let me just share my screen. Can you see my screen?
Yes, we can. Maybe you can put it on slideshow. Yes, nice, good.
It's on slideshow, okay. So my name is Dr. Phoebe Juma. I'm a physician in the infectious diseases unit at Kenyan National Hospital. So I'll just be talking briefly about long COVID. This is an outline. We'll just go through a few areas, definitions, epidemiology, a bit about pathophysiology and management. So what is post-COVID condition? There's a bit of a difficulty with defining this as an illness initially, but finally the WHO convened a panel of experts and they came up with a definition, which is what is now currently in use. So the post-COVID condition is a patient with a history of probable or confirmed COVID-19. And this patient is 3 months from the onset of COVID-19 and has symptoms that have lasted longer than 2 months. They can be new onset or persistent from the acute episode of COVID-19. And then it's a diagnosis of exclusion. So these symptoms cannot be explained by an alternative diagnosis. So there are other definitions that had been there previously. So for example, the NICE criteria, where there was acute COVID up to 4 weeks, ongoing COVID-19 from 4 to 12 weeks, and long COVID for symptoms beyond 12 weeks. So that's a name which may be familiar to us. Terms used for this, post-acute sequelae of SARS-CoV-2 infection, post-acute COVID-19 chronic, post-COVID syndrome. But what is also important to note, there's no widely accepted diagnostic criteria for this condition. It's just the timing that is important. So post-COVID conditions are heterogeneous. There are several patterns which have been identified. So you could have persistent symptoms from the acute illness, then you could have new onset of symptoms, and then the symptoms the patient has could also evolve. And these symptoms are attributable to different underlying pathophysiological processes, which we'll come back to later. And yeah, so in terms of epidemiology, what I can say is that these symptoms were expected, because from previous experience with the SARS and the MERS outbreaks, these symptoms were described. They described conditions like with the strange names like myalgic encephalomyelitis, chronic fatigue syndrome, mast cell activation syndrome for patients who had survived those viral infections. So with COVID-19 also, symptoms have been described. The prevalence of symptom varies. It depends on the series, the criteria that was used, the symptoms that are used in that study, and when that study was done in relation to the onset of symptoms. So for example, was a study done at 3 months, 6 months, or a year after the onset? So the figures, the variation is quite wide, like from 5 to 80%. So on the table on the right, I've just listed the commonest symptoms. So this includes things like fatigue, dyspnea, chest discomfort, cough, and anosmia. And you can see a whole wide range of symptoms from the different body systems. The patient can have a wide range of symptoms. So including insomnia, alopecia, sweating, diarrhea. They could have psychological symptoms like PTSD, impaired memory, poor concentration, anxiety. And on a whole, the persistence of these symptoms leads to a reduction in the quality of life. So this table just is most symptoms the patients could have. So are there risk factors? Are there people who are more likely to have these symptoms? So some of the things that have been raised, risk factors that have been postulated are an older age. By older age, they mean age above 20 years. People who have a higher BMI, if you have certain comorbidities, for example, allergies or obstructive airway disease, female sex, and then patients who have more severe symptoms at the onset are more likely to have post-COVID conditions. But it's good to note that even those with mild COVID can still develop post-COVID condition. Then there are certain things which are associated with a reduced risk. And I think most importantly is the vaccination for COVID. So patients who are also treated with certain agents were noted to have fewer symptoms, persistent symptoms like the interleukin-6 antagonists. So what is the time course? How long do these symptoms last? So it's variable and it can be related to the severity of the illness. So in one study on hospitalized patients from China, they found that at 6 months, those patients, 74% had symptoms. And at 12 months, a significant number, like still 50% still had symptoms. So for patients with milder acute illness, fewer patients, their symptoms resolve faster and they have less severe manifestations. So what is the pathophysiology underlying this post-COVID condition? So what has been said is that post-COVID syndrome is real, but the pathophysiology so far is uncertain. So it is thought that there are many different mechanisms may underlie these different manifestations that the patients have. So some of the postulations include maybe these symptoms are just due to the organ damage that you suffered from the acute phase of infection. So the patients had hypoxia, you had these metabolic derangements, you were on all these medications, you were admitted in ICU for several weeks or even up to months. And as a result, you have these symptoms developing. So maybe another postulation is maybe dysfunction of the renin-angiotensin-aldosterone system. So the angiotensin 2 may be accumulating and you get vasoconstriction, proliferation, and it's also profibrotic. And this may contribute to some of the symptoms that the patients develop. There may also be immune dysfunction. The acute COVID is a pro-inflammatory state, so there might be persistence of some of that inflammation. Those high levels of cytokines during acute illness lead to abnormal activation of macrophages, and especially in sites like the CNS, where the microglial cells, when they are activated, they damage the neurons. And maybe that's what leads to some of the neurological symptoms. Then there's also COVID, you knew there was thrombophilia, was a thrombophilic state. So maybe you're having small microthrombi in the vessels, and this may be producing the symptoms that you see. It's also thought that maybe there is viral persistence in certain sites, and this leads to persistent multiplication and inflammation and produces the symptoms. There's also a theory of that inflammation triggering degeneration of neurons. In some studies that I came across, there's also a thought that it could be immune mediated, like the post-COVID, the infection leads to increased production of autoantibodies. And there's actually an increased risk of autoimmune diseases developing post-COVID, post the acute infection. So these are other, I think it's basically saying the same thing. So immune dysregulation with viral replication. So that immune dysregulation could also lead to reactivation of latent infections, so including things like the herpes viruses. Another thought was dysbiosis, where SARS-CoV-2 had impact on the microbiome. And then these changes could lead to symptoms, for example, in the GIT, causing abdominal pain and diarrhea, and that persistent diarrhea. We had already mentioned autoimmunity. We had talked about endothelial dysfunction, and then there's also could be dysfunctional signaling in the brainstem or the vagus nerve. So this slide is just summarizing what we have said. So there are events that occurred during the acute infection, during that inflammatory phase, and then during recovery, and all this could be contributing to the prolonged symptoms that you have. So in the acute illness, the treatment you got, the complications, the damage to your organs, the comorbidities you have, and all the drugs you used causing your prolonged symptoms. You could have gone to the inflammatory phase, you got a cytokine storm, which altered your immune status, including the medications you used, you got another infection, or because of that inflammation, you got prolonged symptoms. Maybe your prolonged ICU stay, you got sequelae of critical illness, deconditioning of your muscles because you are immobilized for this duration of time, and you got prolonged symptoms. And lastly, and I think very important, there were psychological issues. So this slide just tries to relate the symptoms you have and what could be the underlying pathology. I want to go through this one. So how do we manage post-COVID syndrome? So from what I've said, I think there could be, varying underlying pathophysiology. So the treatment, the management of these cases is individualized, and you might actually need to refer these patients to specialists. So like all management for medical conditions, a good history and physical exam, including the events surrounding the acute COVID-19, the severity of illness, the treatments, the complications this patient had, the comorbidities is important because all this will inform your diagnosis. So your laboratory tests, of course, depending on your findings in history and exams, you'll have to do targeted tests. So some baseline tests you could do include things, the usual TB, total blood count, biochemistries, and then there are other tests you consider depending on the patient's presentation. So for example, in unexplained fatigue, you consider thyroid function. Maybe what we should mention is that COVID-19 testing is not a part of this, of the long COVID syndrome diagnostic workup. Yeah. Then other management you tailor to the patient's presenting symptoms. So anticoagulation, not routinely done unless the patient has BT or DVT. And then there's also a role for rehabilitation, for patients with maybe exercise intolerance or aching joints and the like. Patients with psychiatric manifestations, you consider psychotherapy. So this is just a summary. Long COVID is an area of active research. So there are a lot of candidate treatments that are undergoing evaluation. So this is just a table summarizing that. It's quite busy. I don't know if you want to go through it, but just maybe in brief, some suggestions. So for post-exertional malaise, they're suggesting treatments like pacing, which means graded exercise therapy. For patients who have postural orthostatic tachycardia syndrome, you consider things like beta blockers. If there's evidence of immune dysfunction, you consult a specialist like an immunologist, and some patients have even required IV immunoglobulins. For cognitive dysfunction, then mental exercises, what they're calling cognitive pacing, may be indicated. And I think so on and so forth. It's the treatment will be tailored to what you find in your patient. So this is my last slide. Is all this preventable? To some extent, yes. If you're vaccinated, you're less likely to get COVID in the first place. Then you're less likely, if you're vaccinated and you get COVID, you're less likely to develop post-COVID syndrome. And even if you develop post-COVID syndrome, you'll get less severe symptoms. So vaccination has also been shown not to increase the severity of post-COVID symptoms. Yeah. Thank you. Back to you, Dr. Chin.
Thank you so much, Dr. Phoebe. That is a fantastic presentation. And I think it answers a lot of questions that people have had around long COVID and how to manage issues around long COVID. It's a very complex area. And I think we managed with some patients in the clinic who have had multiplicity of symptoms, new symptoms developing even close to 2 years after their presentation. And sometimes assigning this presentation to the COVID or trying to figure out what else could be going on is very complex. So thank you for that presentation, and thank you to all the speakers. That was excellent. A shout out to Dr. Thuranira, who was our moderator of the COVID updates for a long time. Now he's very busy, but we are really glad that he was able to join us today. I think we have a number of questions, and I'll just go to the Q&A. If you have anything for the Q&A, please put it in the Q&A and then we'll be able to answer. I've noticed a few members from the media who've asked some questions and are interested in some stories. I think the main issue for us and what the message we'll be taking out to Kenyans is, one, at the moment we have very few cases of COVID. We'll continue to have the occasional cases once in a while. We have a lot of respiratory tract infections. Most of them are because of other viruses other than COVID. Where we have COVID, it's important that you get appropriate treatment, so not to rush to the pharmacy to buy antibiotics, because that will not be useful to you. For the healthcare workers, there are very good guidelines, and Dr. Wangai, I think, showed many of the guidelines that exist for treatment that we'd really recommend that you refer to. So maybe we'll just go to the questions. So the first one is for Dr. Okunga. So someone asked, are there COVID-19 cases today? And then maybe the other question is regarding the epidemiological surveillance that's being done. Is the positivity rate purely PCR positivity? We know that a number of hospitals also do the antigen tests. So the ones you presented, were that purely due to PCR positivity, or what other testing are we doing? Thank you very much.
Do I reply?
Yes, please go ahead.
So thanks for those questions. I think COVID cases have never ceased. We always have COVID cases around. So our concern is really not about whether there is zero COVID cases, but whether there is an upsurge beyond what is expected, and usually our cutoff is about 5%, then we start getting a bit concerned. For the positivity rate is combined, both PCR and antigen. So I think that is really about clarification. Back to you.
Okay, thank you very much. There was a question about, and this is an important one, about whether there's any policy guidance on mainstreaming COVID-19 services and integration with other disease areas. So you may remember that when COVID first started, there was a lot of programs purely for management of COVID. Where will you screen them? Where will you isolate them? COVID units were set aside separately. And I think we've gotten to the point where we're learning we live with COVID for a long time. It will be like any other of the viral infections that we're seeing. And the aim is really to be able to identify it so that for patients, as Dr. Okunga had mentioned, who have severe respiratory symptoms, you want to test them for COVID so that those who are positive may be isolated, particularly if you're going to manage them in a ward that has other patients who are at high risk for severe disease. So if you have patients who have kidney disease or who have malignancies or who may be on immunosuppression, older patients with diabetes, then you clearly want to protect those patients. But I think the aim is not so much to set aside parallel programs purely for COVID-19, because we now have to live with it, and we also have to take care of a lot of the other disease areas. Okay, so Dr. Wangai, someone is asking, what about cough suppressants? I think it's very common to have people use cough suppressants, and it's probably a hot selling item. Is there any evidence for their use?
Yes, I think it was just a couple of days ago that a circular went out saying a certain provider is no longer going to support cough suppressants. Yes, it's a very controversial hot topic right now. We do know that really the mainstay of viral illnesses, when you have a viral URTI, upper respiratory tract infection, is actually more of antihistamines. So, like cetirizine, just things to be able to help with a symptomatic relief, indeed. Cough suppressants have a number of side effects as well. And I think that's where a lot of the concern is right now at the moment. So for a patient really who has a flu, I would say, even people talk about home remedies, ginger, lemon, and whatnot. At the end of the day, I'd say focus more on antihistamines for 2 or 3 days, and viral diseases are self-limiting. They will naturally go away on their own.
Yeah. Okay, thank you very much, Dr. Wangai. And Dr. Juma, there's a question here about, is there any correlation between female sex and post-COVID symptoms?
Well, yeah, it seems from the studies that were done, the female sex were more likely to report post-COVID symptoms. But it's not known whether it's because maybe women are more likely to respond in those studies, to be respondents in those studies, or are more likely to seek medical care. But it's true, there was a correlation that was found between female sex and the post-COVID symptoms.
Thank you very much. So that's an interesting one. More men probably had more severe symptoms, but more women more likely to report positive post-COVID symptoms. And as Dr. Juma says, it could be health-seeking behavior. They're more likely to respond to phone surveys and the thing and such. But I think maybe then if you see, particularly females who've had severe disease, then you want to talk to them about post-COVID and how they can manage some of the symptoms, including very early mobilization, encouraging exercise, and a lot of those things that they possibly can do for themselves. Dr. Kunga, this one will probably be for you. So the question is complex, but I guess the one you can help us answer is that the cost of COVID testing is prohibitive. At this point, where can people go to for testing where that is needed? I guess if people went to the hospitals, it can be done there, but is there anywhere else where people can go for testing?
Oh, thank you, Dr. Mbajo. And I think there are two questions that need to be responded to. One was the transition policy. As you know, the Director General WHO declared the end of COVID as a public health emergency of international concern. And part of the transition expected of member states is to now mainstream COVID services within the routine health services. So surveillance is integrated within the routine surveillance. And then even the management of cases, same as testing. In terms of testing, COVID testing in all government facilities is supposed to be free. So that's the health facilities, and we also have points of entry, and that is border crossing points and airports. We may not have control of what is happening in the private sector, but at least in government facilities, COVID testing is meant to be free.
Okay.
Back
Thank
to you.
Thank you very much, Dr. Okunga. And there's a question about children, and I think I saw Dr. Anne-Marie with us. Anne-Marie, I don't know if you're able to hear us. There's something about investigation of COVID in children with URTI. I don't know what your current experience is with children, what you're seeing with a lot of children have had URTIs, particularly in schools. I'm hoping Dr. Anne-Marie is still here with us.
Hi,
Good.
Doc. Sorry, could you repeat the question?
Yes, there's a question about investigation of COVID in children with URTI. And I was just asking, one, about your experience currently with children. How much COVID are you seeing with children, particularly with the current, very frequent outbreaks of URTIs in schools? When should we be testing children for COVID? Yes.
Okay, thank you for that question. So my experience, for example, at Kenyatta, we're not doing a lot of testing, that I must admit. But then there's the surveillance that KEMRI does for acute respiratory infection at Kenyatta. And what we have been having is a few cases of COVID, but a number of them have also had influenza A co-infection. So if I give statistics like, say, over the last 3 weeks, I've had 2 patients who have been COVID positive, but they were also influenza positive. In the private hospitals where they're doing more testing, I think we have been seeing more of influenza and RSV and just very few cases of COVID. And we really don't tend to test the outpatients who are stable because of the cost of the test and really what treatment are you going to give that otherwise stable child. So just like other respiratory tract infections, it's just supportive care and even reassuring parents. Yeah. So I think it's just like the adult situation. We've not had too much of COVID. Thank you.
Thank you so much, Dr. Anne-Marie. So there's an interesting question here, and I don't know if any of the panelists would want to take it up. And this is about the need for COVID booster vaccines. I think a couple of people have asked that. Should we recommend annual boosters? What are your thoughts? I don't know who wants to take this one. Dr. Wangai, what are your thoughts on this one?
Oh my, I was hoping you would not pick me. Well, we don't have too much data actually supporting the use of booster vaccines beyond the 3rd dose. So we know we strongly recommend you get the 2 of the primary series and then 1 booster that can happen anytime a year after the first 2. But 4th, 5th, 6th, 7th, 8th, nth doses of booster vaccines, we do not have any data supporting any benefits that are added onto that. Really, at the end of the day, we know that the vaccines have elicit a very robust immune response. I think even Professor Anzala had a session yesterday when he talked a bit about that. I mean, I'll just give you an example. I now have probably about 2 COVID inpatients right now, and they were vaccinated just with the primary series, and I think one of them got the booster. And the case is, very mild. They're on oxygen, but responded very well to treatment. And so really, we know that just having your first 3 shots is more than sufficient. Yeah.
Okay, thank you. Thank you very much. And there's a question around prevention of sort of the PTSD in patients. And I think Dr. Juma had talked about some of the things that can be done around prevention. And maybe Dr. Juma, you might just want to give people some 3 key points. What can we do, particularly for patients who are ill, to get them up and about and maybe reduce their risk of having persistent symptoms beyond COVID?
Okay, so I think it's important to mobilize your patients even when they're admitted, and the role of these other, I don't know whether to call them allied healthcare workers, like the physiotherapists, the counselors are very important. And we found them very useful when we had our patients admitted with COVID-19 at Kenyatta. So ongoing physiotherapy, maybe your counselor in case the patient has issues. I think being alone in an isolation is very difficult. So allowing relatives to visit, but keeping the relatives safe, making sure they're wearing appropriate PPE can be helpful in managing these psychiatric conditions. Thank you.
Thank you very much. And I think I see two questions from Dorcas Wangiro. One, it's about, I'll allow Dr. Okunga to answer the one on the XBB variant, and whether this is now endemic. And I think for me, again, and for media, is that we have nothing to panic about. So any reporting should not be to raise any alarm as at this point. And where there is a change that's noted, the Emergency Operations Center that routinely reports on COVID will be able to highlight that we're at a point where an alarm should be raised. Is there COVID readily available in Kenya? I think the answer is yes. The Ministry of Health has received quite a large amount of Paxlovid. I think the amount of Paxlovid we have versus the number of patients we have means that we may not be able to use all of it in time. But yes, Paxlovid is available in Kenya. So Dr. Okunga, if you could talk about, is it correct to say that COVID-19 is endemic? I think you'd already mentioned that. And yes, we will continue to have mild cases of COVID over time. Those who are at high risk, a few may end up in hospital. But then the question about, there was a death of a healthcare worker and some cases reported in Taita Taveta. I don't know if your unit was involved in that. Was it truly COVID-19? And what's been done in the area? Have we seen any cases beyond that? Thank you. Dr. Okunga.
Thank you, Dr. Mbajo. On the issue of endemicity of COVID, I think the verdict is still out there, but largely what we expect, we do not, unless some very peculiar event happens, we do not expect the virus to just disappear from the face of the earth suddenly. So we'll see it around. I think that's the normal expectation. And we'll see circulations of various variants, and that's why we've put in place surveillance systems for monitoring the variants and monitoring the severity of the various variants so that we can guide response. On the issue of Taita Taveta, it is true that we lost a public health officer, a senior public health officer there. He had a positive diagnosis for COVID. But as you had rightly indicated, when we look around the country, we have upsurges of pneumonia cases in different counties. And a number of pathogens have been implicated, mainly flu, influenza A. They've also been Haemophilus influenza B, and of course COVID. So we still would advise that we do investigations case by case and manage as per the individual patient's presentations. So it is true that we lost a public health officer in Taita Taveta, and there was an upsurge of cases there, just like in a number of other places around the Lake region. We also had upsurges around in many places, but those upsurges have largely come down. And therefore, there's really no cause for alarm now, but we need to protect the vulnerable populations. Back to you, Dr. Mbajo.
Thank you very much. And I think the next question is an interesting one. Does the current COVID testing provide a true picture of the extent of infections in the community? I think extent of infection starts from one. One is from seeing an upsurge of symptoms even before you get to the point of testing. And the issue of how much do you test is also an interesting one, where you have a largely mild disease that is now, we now know more about it. People who have mild infections in the community will probably not even know they were infected, may have mild infections and may not even require specific testing or specific management. When COVID first started, it was important to test. We knew very little about the disease. We knew very little about its transmission dynamics and which populations are most vulnerable. But I think as knowledge improves, we also have to change, so that the point now is to know, not to know every single person who might have infection, whether it's mild, asymptomatic, or the rest, but to be able to identify particularly those who are at high risk for which we may need to do something different. So there's something about hypercoagulable states. There are certain vaccine brands that worsen this hypercoagulable state. So, and how bad is it compared to the natural disease process? And maybe just to quickly answer that one, that the disease is definitely associated with hypercoagulability. At the height of COVID, we saw patients even get bilateral limb amputations because they had arterial thrombosis. We saw a lot of DVT, we saw CVAs and the rest. So you cannot compare what you see with the disease with what may potentially be present with the vaccine. So I think prevention is always better than cure. Okay, we're just about to run out of time. So this is an interesting question. Should we continue advocating for mask use, and in which location specifically? So I'll tell you what I'll do, then I'll pass it on to the other panelists to tell us what they think. So for many of you who may be healthcare workers working in hospitals, working in clinics, a lot of patients will come to you with various upper respiratory tract infections. I would recommend that in a hospital, in a clinic, you wear your mask, because you're not just thinking about COVID, but you're thinking about flu, you're thinking about RSV and rhinovirus and the rest. And every patient who comes into contact with you may potentially have some upper respiratory tract infection. So for your own sake as a healthcare worker, I think it's very important to keep wearing your mask. So in terms of the other locations, let me go around and see what the other people think. So Wangai, Phoebe, then Okunga, what do you think? Wangai, we'll start with you.
You know, the interesting thing I realize is that throughout the whole of the COVID pandemic season, 2020, 21, 2020,
Uh-oh. You seem to be breaking. I don't know if it's my internet or...
When we were fully masking. Oh, sorry. I think it's better now. Yes, so actually, for those 3 years in the COVID pandemic season, I actually did not get any homa, any cold, any flu. So I realized, my goodness, the mask is actually helping. So personally, I wear masks because I don't like getting flus. Flus really take me down. But I'd definitely advocate for healthcare workers, also in public settings where there are crowds. So for example, if your local church, you know, is one of those big mega churches and everyone is squeezing each other, I would recommend at least wearing a mask just for your own sake, preventing URTIs. We also know that for those few people who are diagnosed with COVID, they're not sickly. So especially the microenvironment variant spreads really, really, really fast. The transmissibility is quite high. And so in such scenarios, I would advocate for wearing of masks. But when you're at home alone with your family, you know, you can afford to put down your mask and show your beautiful smile.
Thank you very much. Phoebe, what do you think?
For me, I think I agree with what you had suggested, that healthcare workers in the healthcare facility should be wearing masks, and maybe also the patients, relatives, anyone coming into contact with a healthcare facility. For other people, I think there's a vaccine, so I think let's take advantage of the vaccine. That way you protect yourself and you won't need to wear masks. Yeah, thank you.
Thank you, Dr. Phoebe. And Dr. Kunga, what do you think of this?
I think I align with what the previous speakers have stated. I would probably just want to add aspects around people providing services in homes for the elderly and maybe other vulnerable groups, people taking care of people with comorbidities. We probably need to find a way of protecting them. The other congregate settings, as Dr. Angai had talked of, where the elderly are likely to frequent, like churches, I think it's good to encourage the whole congregation to protect the rest. Over.
Thank you. I think I totally agree with your thoughts. There's one interesting question. Someone asked if the Ministry of Health facilities would provide travel certificates post-testing. I know most countries have sort of dropped the need for a test prior to travel. I'm not sure if there's countries that are still insisting on a test prior to travel. I know as of December, our neighbor Tanzania, you either needed to show a vaccine certificate or a test, but I think a lot of countries have now dropped the requirements for that test. But if you know of any countries, you can tell us so that we also check and know which countries are still pushing with some of these measures. Okay. I'm trying to see if there's a question that hasn't been answered at all. Maybe this one is for Dr. Ongai. Does COVID cause lung scarring? And if yes, does this clear?
Yes, just like any other inflammatory disease or illness affecting the lungs, we have seen a number of patients who ended up healing with scarring or what we call lung fibrosis. And if very severe, they end up having lots of chronic respiratory symptoms, some background dyspnea on off, intolerance to exercise, some cough, or some chest discomfort as well. As some of the chronic sequelae of COVID, especially those who are the severe and critical category.
Okay. All right. Thank you very much. I think maybe we'll probably just answer our last or second last question. There's a question about hearing loss post-COVID. Dr. Phoebe, I know we've seen a patient who had hearing loss post-COVID. Is it reversible? I don't know. What do you think?
Okay, that's a difficult question. I think it's hard to say, but we'll need to be informed by data, by following up from studies on the post-COVID syndrome. So I've only had the experience of that one patient. So he had presented at first with erectile dysfunction. In fact, we thought it was a psychological problem and referred him to the mental health clinic. Then now came with new symptoms of hearing loss. Was followed up by the ENT team and had a hearing aid inserted. So eventually we referred him to the neurologist. So I'm not sure. I think we'll have to study, follow up the patient and see.
Yeah, I think we'll be informed by time. We don't have sufficient experience on how long some of these post-COVID symptoms will last, but it'll be interesting to see more people publishing some of the experiences. So for many of you who are managing patients, please publish some of your experience because that's where the data comes from. So I think we will stop there for now. Thank you all to the speakers for a fantastic job, really excellent presentations. And thank you to our audience for the very excellent questions and the discussion that this has elicited. I think for now, we're in a good place as far as COVID goes, and we pray that to continue to be in this good place and do our best to protect ourselves, to protect our loved ones, and to protect our patients. So thank you all and have a very lovely weekend.
Thank you. Bye-bye.
Thank you. Bye.